So welcome everybody to the Interoperability Roundtable. This is an open forum fostering conversations around interoperability. I'm Jake Tunney, product manager at Leap Orbit, and I'll be your MC today. And we are joined today by hosts David Finney and Mrinal Bhasker, co-founders of Leap Orbit. Leap is the trusted innovation partner to many of the biggest market-leading health data networks, including CRISP, Manifest Medics, Sync Health, as well as the policymakers who oversee them. And we are currently working on improving the accuracy and accessibility of provider data with our product Convergent, which is a provider data platform. And as always, we'll be looking for an open conversation today and participation from the audience. So please drop your questions in the chat. And our guests today are Ron Urwongse and TJ Theogaraj, founders of Defacto Health. And I'll give a brief bio on both of them, and then we'll kick into the main session. So Ron has a lot of expertise in provider data, especially technology strategy, product management, and new product innovation around the subject. He brings 13 years of experience in healthcare technology, having managed products in infection surveillance, patient self-service, health insurance exchanges, provider data management, and interoperability. He's established product teams to manage multi-million-dollar product lines and has launched products used by millions of healthcare providers and hundreds of payers. And TJ is passionate about creating innovative technology-enabled solutions to complex healthcare problems. He has also led product teams for multi-million-dollar health tech platforms, taken products from launch to significant market share, and led new product discovery and design at small startups. His specialties include product strategy, roadmap planning, product design, go-to-market, financial modeling, and cross-functional alignment. So Defacto Health is a relatively new venture of both of yours. So I would love if you could give a little bit of background on Defacto and why you started the company.
All right, thanks, Jake. So this is Ron again. So Defacto Health, we're a product management consulting company as well as a data services company. We're really focused on the availability of emergent data sets. So, the government is taking a lot of actions to encourage, require hospitals and payers and other types of healthcare organizations to make transparent data that they may have not have made as transparent previously. So, machine readable data that you can use for all sorts of use cases. So, we really thought there was an opportunity for somebody to, get in the market, take a look at all these data sets, figure out what the data is good for, figure out the warts and things that might need to be ironed out and fixed in the data before we can really make use of it. I guess a fun fact, TJ and I have known each other and we've worked with each other for over a decade across multiple different companies. So we have a lot of experience launching products together, and we wanted to keep it going and start Defacto together to see if we could find some new innovations that we could work on. So that was another motivation.
So Ron and TJ, we're really excited that you guys agreed to join us for this discussion. When we were introduced to you, I felt like we were kindred spirits in some of these topics. I mean, we at the times kind of felt like we were alone in the wilderness, talking with plans and the sort of vendor ecosystem about FHIR APIs and the interoperability rule. And I think especially the potential and the importance for provider directory APIs specifically. There was so much attention when the interoperability rule was released around patient access, and I think for good reason, because it's a complex, sensitive set of issues all the way around. But sometimes that meant that provider directory was treated as an afterthought. A health plan might contract with a vendor that may be really well suited to address patient access, and then they sort of threw in provider directory as an extra piece, right? I think you guys, like us, see the potential not just for sort of a democratization of network information, but the accessibility of these APIs. While we've been focused on sort of delivering them for payers, you guys have kind of taken the other side of things, and you've been looking at the health plans from the outside in. I know you've done a lot of work kind of inventorying what's out there in the market, which payers are offering APIs, what data sits behind them. Can you share a little bit with us about the work that you've done? TJ, you want to take that one?
Yeah, totally. The inventory side is typically the starting point for our process. So the interoperability rule requires payers to publish their directory APIs and make that information available. One of the things that we found is it's not always so cut and dried, and whether it's intentional or otherwise, sometimes it's a little bit of a struggle to find out where the APIs are, how you connect to them, documentation, that kind of thing. So I'd say right now, we're a little over 6 months into the implementation and the regulation coming into effect. I think we've got about, maybe of the top 50 payers, maybe around 40 of them have made their endpoints available. And just a note on measurement, when we talk about the top 50 or the top 30 or whatever, we're looking in terms of just membership coverage, right? So how many covered lives does a payer have? That's our basis for measurement. So we've been focused on getting the biggest amount of coverage that we can. So from that angle, of the top 50 payers, who account for about 85% of total covered lives, about 40 of them do have their APIs available. As I said, it's not always been pretty straightforward being able to find those APIs, but they're out there. I think the ones that we've seen where that are missing tend to be the state Medicaid organizations, although the interoperability rule covers them as well. So state Medicaid organizations are also covered by the interop rule and required to publish APIs. But a lot of states that we're seeing just don't have their APIs available as well. And then as you kind of move out of those top 50, there's a fairly sharp decline in terms of covered lives, and it's a pretty long tail that you get over there. And compliance just gets lower as you move into maybe the next tranche of 50. I think we've seen about 30 of those next 50 have their endpoints available. That's kind of been our observation. And I guess I should say, maybe more of them have their endpoints available, but they're not that easily discoverable. So maybe they're out there, but they're not really easy to find. So that's kind of been our observation. Ron, I don't know if you had anything that I missed that's additional that you think is worth noting.
I maybe a fun tidbit, and I'm not sure how actionable this is, but even before the enforcement date in July of 2021, there were a handful of payers that were already publishing their provider directory APIs, and that's what really caught our attention. We were, because we've been familiar with the rule. When the rule came out, we popped it open like a Christmas present, and just dug into all the details and see what it meant for the industry. And then come May or June, when the API started to actually trickle out, we thought to ourselves, oh my gosh, this is for real. Like the payers are actually publishing this data. So first thing you do, you pop open Postman, and then you see what you can find there, and one thing led to another, and that's how we that's one of the big reasons we made our decision to start Defacto, is because, hey, this data is real. We can actually do something with it. But yeah, it was neat to see the early payers publish, and it's a mix of really big ones and a couple of kind of medium-sized ones, and the ones who were publishing early, some of them are just beautifully compliant and conformant to the standards, and have just been it's been really easy to kind of navigate their APIs. The ones that are coming out a little later, a little bit more there might be some more issues to iron out. And so I think the early guys have the advantage of having been out there for a longer period of time and having had the benefit of getting issue reports from us and from others so that they can iron out all those issues.
So, I mean, some of those very early adopters are the biggest of the big, and so they have dedicated interoperability teams that they probably were doing other types of things with Fire, which has not been the norm across the payer market at all. But as you point out, some of them are not the megas, right? Have you seen sort of any? Can you characterize them in any way? I mean, these early adopters that aren't the megas, are they forward-leaning technology organizations? Are they have really loud government affairs and compliance people? What do you think motivated them to be ahead of the pack?
I mean, you had a couple of nationals, you had a couple of blues that published, and then outside of that, just some random small guys who I guess were, like you said, they probably just engaged with their vendors earlier on, or their vendors had pushed them to be conformant early on. CMS had released, as part of the rule, they were encouraging payers to comply early. Now that's not enforceable, but that's some motivation. So maybe some of those guys are saying, hey, maybe if we publish early, you can get some brownie points. Not really sure, just speculating what conversations actually happened in those rooms.
Jake, you brought up a good point, I thought, which is whether this is just responding to a rule that CMS has put out, or whether you're an organization that interoperability is kind of baked into your DNA, and you see it as something that's important to do. And I think that maybe goes towards where you see your role as an organization in the healthcare system, whether you kind of think of yourself as a standalone entity, or whether you recognize that you're, really speaking, part of an interconnected web of multiple organizations, and it's important to make sure that information can flow to those different endpoints. And so I think the organizations that see themselves that way and have already taken steps even before the interop rule have probably been better positioned, certainly technologically, but also I think in terms of internal organizational culture and willingness to share data and that kind of thing. I think just probably better positioned in that sense.
Yeah, it reminds me. So, I don't know if you guys have seen the movie The Martian, and you've got the U.S. government, the Chinese government, they're collaborating to, save Matt Damon. It's kind of like we're seeing some of the same thing here, where you've got interop people on both sides, and they're able to, they talk the same language and they share some of the same mission.
Yeah, I agree. Ron and TJ, great to have you on. There are a couple of things I wanted to dig a little bit deeper into. One is, Fire has brought a lot of innovation and innovation potential to healthcare. And as we look forward to some sort of cutting edge things, the thing that comes to my mind is bulk Fire. And their use cases, and probably one that you are keenly looking into is, you can obviously search for a doctor, whether you want to search by specialty or zip code or other things, and Fire empowers that. But what if you wanted to download the whole data, right? So you can run your own analytics and other things on top of that, right? So, and any kind of data aggregators, and we consider ourselves one that can sort of bring market intelligence to the market and really put this data to use. Did you look into if what percentage of these plans are actually enabling bulk Fire APIs?
So I've personally interacted with one, and it was nice to see it, because you hear about it and then you see it in the wild, and it's kind of neat. I know that some of your customers are doing it as well. But it's the minority.
Yeah. Okay.
I think round two, right? And I don't want to name any names on this discussion, but I think there's two. Well, one that is maybe thinking about a little further ahead, another who, in response to some of the querying that we've been making, we've talked about, oh, if they set up bulk on fire, that would facilitate more efficient data transfer.
Yeah.
So, Mrinal, to your point about what's the use case that you're actually trying to solve for? Is it an individual searching for one practitioner, or is it, large-scale transfer of data? It's horses for courses there. But as Ron said, it's by far the minority. We'd be super excited to see some of that, because in what we've set up, one of the things that we've really had to focus on is how do you get data at scale when you're making these individual queries. So I would love to see greater adoption of an implementation of bulk on fire.
Yeah, TJ, that's a good point. I'm not a lawyer or an expert in federal regulation, but I think that there's some ambiguity in the rule about whether bulk fire is a requirement or not. We've implemented it for one of our customers, but I think to really unlock some of the use cases that are potentially out there, it's got to be a piece of the puzzle. I was looking at the API of a health plan yesterday. One of those early adopters, I won't name. It's a truly public API, which is great. But there is throttling and pagination of the responses, which creates challenges for harvesting data. And the way they to their credit, they explain why they've taken this approach, and they said they have the ability to do anything that might prevent any sort of harm to the plan, right? Which, when you think about patient access, it's kind of obvious what types of things you'd be worried about. This feels like a little bit of a stretch, but I guess there could be some arguments to make there.
Yeah, we've heard of some of those interpretations that, well, if it looks like a DDoS attack, then we'll characterize it as such and respond accordingly. I mean, we've been having pretty open discussions with the health plans that we've been interacting with and saying, well, what are you guys comfortable with, and we'll accommodate and we'll also have discussions about what's the most efficient query path that will help both of us out, right?
Yeah, we certainly recognize that we live within an ecosystem, and it's important for us to be good citizens of that ecosystem. So I think we're, as Ron said, definitely working with the plans to figure out what's optimal in terms of querying. And I mean, I've been heartened to see on the plan side as well, real willingness to participate and have those discussions, and especially their interop folks are really interested in understanding what are the use cases and how that data will be used. I mean, I kind of think of it from, if I were on the payer side and this regulation is coming down, I've got to build something that is pretty open-ended. I mean, CMS effective essentially said, build it and they will come, but they didn't say what they would come and do and what they would want the data for. So you're kind of, as a product manager, I always think of what's the end use and what's the job to be done, and you kind of build your product based on that. But building when you don't know what the use case is and it's kind of emergent is hard. So I think I recognize we're more in the early stages of this, and it's going to evolve.
I mean, some of that is technical and business issues. Like, as a vendor, you're negotiating a service level agreement with a payer, and you're saying, well, is there some, like, what are the expectations around performance? What is there some upper limit on the volume of transactions you might need to support? And the answer is, who knows, right? You really don't know.
Yeah.
But I think there's also a creative exercise, which is that there's sort of some limitless world of possibilities out there that entrepreneurial, creative people could bring to this data and say, I see a use case here, or I see a business opportunity here.
Well, and it gets really exciting when you think about all of the data sets that are coming out. So, you've got your provider network data, you've got some formulary data, and then eventually you've got the price transparency data. There's all sorts of interesting cross-pollination opportunities there.
Yeah, and sort of looking inside out from a health plan perspective, when I'm advising a health plan, I'm advising them not to think of this as a one-off thing, right? I mean, if you really think about provider data for the enterprise, even internally, you're going from a mindset of multiple silos of systems that sort of have their own views of the data, and then you use sort of bulk transfer of data from one system to another on a regular basis to keep them in sync, and it just doesn't work. And so a more API-centric approach where you have sort of a source of truth system in the middle, and then all the other systems sort of work with it real time. You sort of from the inside, you're thinking, if we build this infrastructure of an API-centric provider data platform, then not only you empower the use cases internally for all the systems, there's the claim system or other systems that are available, but then you are also making the same data, right, with no latency available for these external use cases, not just for interoperability's sake, but also interoperability rules sake, but also to your partners and external folks that you need to communicate with on a regular basis. So it's really sort of, use this opportunity, a regulation that has come down, use that as an opportunity to invest in some good technology instead of just doing a patchwork of, hey, we're just going to slap an API on top of legacy systems that just can't scale. Which is the other thing we see in the market, which is, there's an API available, but when you hit it, half the time it returns an error, right? So whatever is powering the backend is just not scalable. So that's the other.
That's a really interesting thing that I hadn't. I guess it's been in the back of my mind. I haven't thought about it actively until you just mentioned it, Mrinal, which is we of course don't have the ability to look under the hood and know what's going on internally on the payer side, but it's pretty obvious dealing with the different APIs from different payers. You can kind of see how some of them are maybe just a layer on top of some internal legacy systems. Like I've seen one where you can't actually make the kind of queries that you would want to or expect to be able to based on the FHIR specification. You have to query in a very specific manner, which if you go to their online provider directory to their website, it kind of follows that same pathway. You have to start with a zip code and you have to say, I want this zip code. It's only once you've done that you get to the next level, which is what's the type of service? Is it medical, dental, etc.? And then once you do that, you get to a still lower level. And so it's this multi-step query that you've got to go through, which totally makes sense if you're a consumer on a website and you're searching through that. It doesn't make sense if you are trying to query the data in, maybe to meet multiple criteria, broader criteria.
Sure.
So yeah, you can kind of guess that they've put just a layer on top of something that existed already.
Yeah, there's reminds me of a book. There's this tech classic, Soul of a New Machine, where you've got these two mini computer manufacturers, and one is taking a look at the others. They just open up the hardware and they can see the organizational structure within the hardware. So it's a similar thing. It's like, whoa, just by looking at the API, you can guess how the backend systems are structured, maybe even how the lines of businesses are structured too.
Yeah. Well, and Ron, I mean, I think this speaks to a point that we've made on previous webinars in different contexts, which is CMS is on sort of a journey of what I at one point called regulatory innovation. And if you're looking to make patchwork solutions to sort of one-off regulations, you're going to constantly find yourself flat-footed. So you know, the plan that took the approach that TJ just described, you know, not 6 months later, someone in their compliance department said, hey, well, now we've got to figure out how to communicate changes in the network all the way downstream within 48 hours of being made aware, right? And if you've just bolted this thing on, or you've generated an extract from some other system and put it in a database that's got a fire wrapper on it, like you've got deeper issues that that sooner or later you're gonna have to reckon with.
Yeah, we've heard of other payers who had previously they were pushing forward master data management strategies, and then I think those guys were probably the best positioned to be able to publish their APIs. And then, to your guys' point, for others, this is an opportunity to bring all of their data in one place, and perhaps the Fire server is the opportunity to manage the data, right?
Mm-hmm. So can we ask you guys to sort of play futurist a little bit here? I mean, this data is becoming available. You guys have probably looked at more of it than maybe anyone. What do you see happening in this market to capitalize on the opportunity? Are there use cases that you think are sort of staring us in the face, or are there companies out there that are starting to do things?
I think there are some of the obvious ones that maybe even CMS had described within their rule about in-network provider search. And it's beyond the health plan's website, being able to do that in the context of other workflows where you're kind of meeting the patients or the members where they're at and where they're already searching and selecting for providers. CMS in their rule, they talk about health plan shopping and selection as well. So those seem to be the ones that are staring us in the face. But I think once you start there, it starts to multiply the other opportunities.
And the plan shopping is an interesting use case, because it kind of really gets to the point of, why does this data have to be available outside of the organization? Like, this goes beyond just going to a single plan's provider directory and being able to start with the plan and say, let me see what providers are in or out of network for this plan. It's being able to look across multiple plans and do that kind of cross-plan comparison. So I think the plan shopping use case is definitely an interesting one. I'm kind of curious to see with physician referrals, whether this ends up becoming something that is a use case that this data can be used for. I think today the situation tends to be with a lot of referrals, it's the physician happens to know someone that, I don't know, they play golf with on Sundays, or they've made a lot of referrals in the past, or they are part of some collaborative group, and it's really knowledge based. They don't necessarily know what insurance that other referred physician accepts or doesn't accept. So I think if you can incorporate this kind of intelligence, maybe within the EMR itself, then at the point of care, when you are with the patient and you want to make a referral to a specialist or another physician, you can make an informed decision based on whether that referred provider is in or out of network. So I think that's a really interesting one as well.
Yeah, I mean, what does interest us initially is sort of the wisdom of the crowd, like as sort of a master data management exercise, the wisdom of the crowd, right? I mean, the more data sources that we can consume and continue to consume on an ongoing basis, the better master provider data set we can build for the whole country, and then sort of bring that to bear for an individual customer. Our hypothesis is that the more data we aggregate, the more judgments we're going to be able to make about which sources are good at which things, right? And then ultimately what you'd like to see is to squeeze as much of the administrative duplicated, undifferentiated, high cost, low value effort that everybody's doing to try to figure out what the good data is and how to keep it up to date.
Yeah, I like that wisdom of the crowds analogy. It's like the jar of jelly beans, and you get 100 people to guess how many jelly beans in there, and they take the average, and they're usually right. I tried to pitch that to my son that, hey, let's would you like to do your science fair experiment around healthcare provider data and make a bunch of phone calls? He did not like that idea at all.
Yeah, I mean, there are perils in our hypothesis. Like it could be the wisdom of the crowds, or it could be a giant echo chamber, right? I mean, if everybody's generating provider directories that rely on MPES, like I'm just kind of throwing out an obvious one, and MPES has all the same issues. You could deduce an address is good because everybody's got it, but it could just be that they're all, the provenance is traced back to a single lineage, right?
Yeah.
So there's a lot of complexity there.
Yeah.
Well, it is interesting though. We know from past experience that payers are putting in a lot of effort to get accurate information on their provider directories, but it's not static, right? Providers move, new providers come into the system, etc. So you've got to keep at it. And it's really hard for any one single payer to have completely accurate data. However, if you can have multiple payers that are, each individually taking some efforts to cleanse and get accurate data for their own provider networks, maybe they don't get to 100% accurate data, but if all of them have some level of accuracy that they're contributing, and then there's the ability to, as we were saying, take a wisdom of the crowd's effort against that. I think the whole can be greater than the sum of its individual parts. So I think there's promise there.
Yeah, I agree. I mean, I think what we're kind of saying is there's probably a cluster of use cases that health plans themselves are only starting to contemplate. Mm-hmm. And then there's another cluster of use cases where sort of the innovation market, third parties, will get a hold of this data and come up with interesting things to do with it. And probably the most, right away, people are going to want to aggregate it and sell it to, market intelligence and marketing and pharma and all of that, right? I mean, they're big businesses that do those types of things.
Yeah, could see that too. There's certainly a number of players who have offerings in those sectors.
Yep. Jake, I know we've had some questions and comments start to pop up in the chat. Is there anything that we?
Yeah, we've got sort of a little bit of a debate going on about how relevant this data even is. So I think that's an interesting topic here, like the concept of why would consumers really care about this? People don't search for doctors on provider directory sites. So what needs to happen for this data to be useful? I think there's something to chew on there. That's from Mano.
That's I think that's true that for most people, a health plan's directory may not be the first place they search, but there have been a number of organizations that have done patient surveys over the past 2 to 3 years, including Doctor.com and Kairos and Yext, and they've all shown that over half of patients use a health plan's directory, maybe not to search for a provider, but at least to confirm that the provider's a network. So it's a little bit more prevalent than one would initially expect.
Yeah, so it's true that a consumer will never touch these FHIR APIs.
True.
But I think you're exactly right. I mean, if you want to know whether a certain provider's in network and what that's going to mean for your wallet, today where you got to go is to your health plan's provider search. I mean, I hesitate to even frame it this way because, but I think to make a point, I will. I mean, I think that the sort of where the FHIR APIs leads us is to a place where, you know, you can pull up a Google search bar, right, and say, hey, Dr. Tunney is my PCP and I want to change insurance. What other networks is he in? And, you know, someday, one way, you know, by hook or by crook, Google's going to have all of the data that sits behind these APIs and will be smart enough to give me a thoughtful answer to a question like that, right? Today, I don't know what would happen if you type that into Google, but I'm guessing you wouldn't get an actionable output.
Or a doctor appointment website like ZocDoc or something that where you're looking to schedule an appointment, emergency appointment to, you know, to get to a doctor, whether it's primary care or specialist, doesn't matter. But that they know, you know, from your profile, this is the insurance you have, and that they can query that that database and tell you, you know, these are providers in network. Like, you know, I can think of a lot of those things. And what APIs really allow you to do is allow these composable use cases that are not tied to a monolithic system. And that's what the long and short of APIs is, that, you know, once you enable these APIs, they empower use cases in ways that were not imagined before, and created a lot of kludginess, if you will, of a lack of better term, in user experience. And, you know, if you look at how Google Maps API, for example, is being used today, and you go back to your MapQuest or whatever before that existed days, and you say the only way to get a map is to actually take the address from whatever place you have and type it into Google or MapQuest to get it on the map. But what about seeing all the providers on the map so you can pick the right provider? Not possible, right? And so it's just a very simple example, but the things that the use cases that it can unlock is really can be game changer for, you know, if I really think about what are we in it for, right? I mean, we are in it for consumers, the patients, for their, and we are ourselves patients, and so, you know, for our better experience overall with the healthcare system, it's a really important part, right? You know, which doctors are in network and which doctors are, you know, covered by your insurance. And I have lots of horror stories and some good ones too about, you know, getting treatment and then not getting, or chasing both sides, the payer and the provider, trying to get the treatment paid for. And that's what I think CMS and the regulators are after, trying to, you know, sort of not make it the patient's problem at all times, that they're having to chase both sides.
So
yeah, I think also, you know, we've been talking about this as kind of the central focus of something, but I think we eventually get to a stage where the data is just so ubiquitous that it just becomes the friction to access the data and utilize it as part of some larger workflow becomes so low that it just becomes part and parcel of some existing workflow that a patient or member is engaged on. So for example, you know, I can envision someone that's got a specific chronic condition going online to look for information about that condition, right? So they're not going online to look for a physician or a provider. They're going online to get information about their condition. And then the site that provides that information and has other content and useful tools and stuff around disease management and that kind of thing, the ability for them to just have a little widget that they can put in the corner that says, hey, here are specialists who are in your region that accept these insurance plans.
Yeah.
That just becomes an added convenience factor, right? So is the patient going there specifically to search for a provider? No, but it's an additional data point that's available to them, and maybe that's something that they find useful. And I think we get there when the ability to get that data is just so easy that it doesn't become this huge kind of endeavor that you've got to engage in to be able to build it out there.
Hey, I've got another point from Sarah in the chat here that I think is relevant to that, TJ. When we talk about having the data be ubiquitous, but I think we do need to remind ourselves that ubiquitous data isn't really necessarily the entire end goal. We want it to be accurate too. So maybe we should talk about this in the context of the No Surprises Act and how, Sarah's point, how do you make this relevant for consumers? Well, if it's not accurate, it's not really relevant. It's not trusted. And that's, how do we see this in the context of the No Surprises Act, where we can maybe use this now ubiquitous data set to make sure consumers can trust it?
I have all of my fiscal note regulatory things in front of me around the No Surprises Act, but if I remember correctly, there's provisions for plans to be able to verify information on a regular basis and then update it really quickly, like within 2 days. And then I guess some responsibility on the provider side to be able to submit information to the plans in a timely way. And there's probably a list of the data attributes that they need to do. So it's coming back. So perhaps this is part of the verification process. It's being able to compare information against other sources to see how good it is, and you have warm leads to fix things that may be less certain to be correct. That might be a potential use case, not a silver bullet, but it's something that could certainly contribute to it. TJ, did you have any other thoughts around No Surprises?
I mean, Sarah's got a good point. Like this has been a problem for years, right? And we've seen multiple rounds of regulation that have been intended to address this challenge of something that you would think should be pretty straightforward, which is this provider in network for me, and can I find them at this location, and can I get an appointment? Like that's just been a struggle for several years. I think adding some of the burden for that on the provider side is going to go some ways in addressing that. I think I saw a white paper recently from CAQH, our past employer, and the American Medical Association that kind of talks about that shared responsibility on the provider side as well towards increased directory accuracy. So I think that's something that will help us get there once you get the providers more actively contributing. But provider side APIs as well to get information about which doctor is at which location, like that could be super useful to help contribute towards increased accuracy. So I'd like to see us get to a more interconnected world in that sense.
Oh, that's a good point, TJ. Every single data attribute in PlanNet also exists within an EHR. You could certainly expose that information.
I think part of Sarah's point too is consumers and probably all of us included just don't trust one piece of data. Even when we find it on our health plan's website, right? The bar is really low for trust, and a lot of consumers, if they're doing the right thing, are probably still going to feel inclined to pick up the phone, call the plan, maybe still not trust, and then call the provider too and see if they get the same answer. I think our observation is that there's a whole problem set contributing to that is related to data operations within the plan itself. So how does a plan know if a certain provider is in one of their networks? Like that is a challenge even within the enterprise, right? Because you've got things that might be happening in contracts that can affect whether a certain provider is in the network. You've got things that are related to credentialing The provider could be sanctioned that impact whether that provider's in the network. And then you have things that are happening between the provider and the provider's employer or affiliated organizations that can impact what's happening in the network. And when you really sort of look at the operational challenges within a plan of kind of communicating that out to the members and all the other places that want to know, there's a lot of legacy technology, a lot of manual process, a lot of spreadsheets and mudging and access databases. And, I think FHIR FHIR is an implementation of RESTful APIs. And so what we've tried to advocate to health plans is you want to have a single place where you've got your trusted data, and FHIR APIs and RESTful APIs in general give you the ability to sort of syndicate that information out to all of the stakeholders that need it. It can be your website, it could be the public with these public APIs, it could be your claims paying system, it could be clinical systems, but you can really eliminate the sort of the latency and the risk that, maybe the network that's in your printed directory and the network that's in your provider search and the network that's in your claims paying system are all out of sync. So I think there's a real potential to fix that set of problems here.
Right. So David, if the five of us were building our own health plan from scratch today, there's the luxury of being able to recognize all of these and build that as the core, and then build other things around that. So you've kind of got that from the ground up. I think that the challenge that comes in is you've got, as you said, legacy systems where there's these big investments that have been made. And I think from a financial standpoint, a lot of the organizations, they are still amortizing the investments initially made on those systems, right? So you don't want to just chuck that away. But yeah, I'm kind of curious to see, as plans look to their next generations of systems and maybe new plans coming into existence today, whether they take that architectural construct and kind of build with those RESTful APIs at the core of things.
Well, CMS also kind of threw this grenade into all of that around those surprises, right? Which is to say, somehow health plan, you've got to get this data moving from one end of the enterprise to the other in a very short period of time. I mean, these are business processes that in a lot of cases might be quarterly, right? Yeah. And now the government's saying, squeeze that down to 48 hours. And there are only so many ways that you can do that, right?
Right, because if you've got multiple sources of truth and you don't have automated processes to figure out which one is right, then you necessarily have to apply manual processes to figure that out. And so that extends it from 2 days to, like you said, a month or a quarter, right?
Doesn't work. Right?
Yeah.
So I think that's the box that health plans find themselves in, and it's a challenging box for sure.
Okay, how do we leave this on a more hopeful note?
Well, I mean, the data is more out there than it was before, so there are more opportunities to get it right. I think there's opportunities for positive feedback loops because the data is out there. We can take a look at it. You guys can take a look at it. There are others who can present the data in front of consumers. Hopefully, there are others who want to present the data in front of the providers themselves so that there's a feedback loop to get it correct. Hopefully, we can get more interoperability coming out of the provider side into the payers so that you can, really compress that time frame. So I think we're starting to see the data flow better and in a more streamlined way. And hopefully there's a positive feedback loop to get the data better and also more useful for everybody.
I want to add as well, we've had some really good experiences with payers that we've been interacting with where, maybe when we start off, there's some issues and something doesn't work the way we expect or something that we just don't understand. And we report it, and some of them have been really good about excited and interested to get on the phone with us and talk about it and understand what we're doing. And then B, recognize that there's something that can be improved or something that needs to be fixed on their side, and have been responsive and quick about addressing some of those problems. Now, I will say that's not been our experience across the board, but I've been encouraged by those players that have been very participative in this process. So I think that's good news as well.
It's exciting for the interoperability guy whose phone never rings when his phone starts ringing, right?
We've made really good friends with some of those people.
Someone's calling me.
Yeah, I do want to re-emphasize a point David had made, and that is just like you look at an industry and look at some of the costs that are being repeated at every organization. And I see clear opportunities to remove some of those duplicative efforts that are happening at every organization. Yeah, provider data is one of those things where power of the collective, power of sort of centralizing some of this data, mastering, cleansing, collating, and enriching can be done centrally by some organizations that are sort of doing that for their living. And then use that, squeeze out costs that you're putting in towards, manning your own teams and putting manual processes and doing all of that, squeeze that out and use that, those savings into investing in some new technologies that will make the data really flow quickly and be available to all parts of the organization and outside.
Well said. Jake, I think that's your positive note to end on.
Awesome. Well, thanks so much, everybody. And thanks for joining Interoperability Roundtable. I wish everybody a really happy and successful 2022. So look to see everyone on the next one.
Thanks, Ron and TJ. Good to see you guys.
Thanks for having us.
Thanks for having us on. It was fun talking interop.
Bye.
Bye.
Bye.